So good afternoon, everyone. I think we'll just kick off now. For those of you who haven't met me, I'm Gillian. I'm one of the consultant neuroradiologists. Thanks very much for joining today. The topics are interpretation of hydrocephalus, calcifications and post-op findings on CT. Now, these are fairly large topics within themselves, and I decided that with Tanvir and Sean that I would change it from a 1 hour session just today to 2 40-minute sessions. So we'll do until 3:40 today, and we will do another session next Thursday, which is hopefully okay for some of you or all of you, again from 3 until 3:40. I think we'll get through hydrocephalus and some calcifications today. So I think we'll end up doing the rest of the calcifications section and the post-op changes next Thursday as a stable. And we can, at the end of this, we can have 5 or 10 minutes to have questions or any queries or any discussions. So let's just kick off then. For hydrocephalus, I'm going to go through the classification and CT appearances, and we're going to look at what features that you can look at on CT to try and distinguish between compensated, acute, different types of hydrocephalus. For the intracranial calcification on CT, I thought it would be worth starting with what you would normally see in patients on CT before we actually move on to the abnormal findings of calcification on CT. And then next week, we'll talk about burr holes, craniotomy, craniectomy and cranioplasty, and we'll talk about some of the complications for each of those. So today, as I say, for those who have just joined, we're going to split the session into 2 40-minute sessions. So hydrocephalus, well, we can split hydrocephalus down into these broad categories. So starting at the top, enlarged ventricles. So moving straight down to the bottom right, obstructive hydrocephalus is also called non-communicating, and as it says, there is an obstruction to the normal absorption of CSF. And then you have communicating hydrocephalus, and if we skip down to the bottom here where it says communicating hydrocephalus, these are the cases where absorption of CSF is obstructed. And again, in this group of communicating enlarged ventricles, you've got these special types. This is where NPH falls and choroid plexus papilloma. So I'm going to show some examples for each of these. In terms of imaging interpretation of hydrocephalus, I think it's really important to start by looking for patterns. So if you have lateral ventricles which are enlarged, you'll assume a third ventricular mass or a foramen of Monro mass, so anterior third ventricle. If you have something obstructing an aqueduct, you'll have enlargement of the lateral ventricles and the third ventricles. If you have enlargement also of the aqueduct, but a normal fourth ventricle, you're going to assume that the obstruction is at the level of the fourth ventricle. And if every single ventricle is enlarged, then it's most likely going to be communicating hydrocephalus. And we will talk a little bit about involution or atrophy as well. So let's start with obstructive hydrocephalus. So we mentioned this is a mechanical obstruction to CSF flow, and the common causes of this are either a mass, and the mass can be anything. I'm going to show colloid cysts today. I'm not going to show obstructing tumours, but it's the same principle, obstructing mass. And the other common thing that we're going to talk about today is aqueduct stenosis. So we've talked already about the pattern of hydrocephalus. So I'm going to show you some colloid cyst cases now, and starting with this case, so this is an axial non-contrast CT, and the ventricles are enlarged, so the lateral ventricles are both enlarged, and there's a hyperdense lesion at the anterior third ventricle or foramen of Monro, and this is typical on a non-contrast CT, so typical location and typical CT appearances for a colloid cyst. Now, not all colloid cysts have high density, and they might be a little bit more difficult to actually see. It really depends on the content of the cyst. So we're starting from here, we've got an obstructive hydrocephalus. So we've looked at the pattern already. So the third ventricle is not enlarged. The temporal horns are a very good place to check for enlargement of the lateral ventricles. If these are up, it's quite a good indication that you've got enlargement of the third ventricles. What about sulcal pattern? That's the next question you have to move on to. So this is obviously at the level of the lateral ventricles, this is at the vertex, and the supratentorial sulci are a very good indication of whether it might be acute or chronic, or whether also it's hydrocephalus or atrophy. So in this case, you don't see really any sulci. You see a little bit of the sylvian fissure here, maybe, a couple of sulci back here. Towards the vertex, you don't see any sulci on the left here. You see a little wisp of sulci on the right. And in young patients, so if this was a teenager or somebody in their 20s, you might think, well, this could actually be normal. But even for somebody in their 20s, to have no sulci would be a bit unusual at this level. So what's the next thing we're going to look at when you've got somebody with obstructive hydrocephalus, apart from sulcal pattern? We're going to look for periventricular low density. Now, in this patient, there is no periventricular low density. And this probably indicates that this patient has had this for a while and they have compensated for this. So this is not an acute obstructive hydrocephalus when there's an absence of periventricular low density. Now, the other thing I was going to mention, you'll see that the ventricles are obstructed but to a different degree, and of course that is possible. The other thing that can produce this ventricular asymmetry is a sort of constitutional asymmetry. So a lot of patients will have one ventricle which is larger than the other. And if you look back at an old scan for this particular patient, so previous imaging, really helpful, you might see that this is actually constitutional asymmetry. But without any previous, you can't really tell. So on the other hand, this is a colloid cyst, much more difficult to see, but in this patient, again, the third ventricle was not enlarged. So you really need to be looking for something in the third ventricle or anterior third ventricle, which is causing the ventricular enlargement. Again, a bit asymmetric, so the right lateral ventricle is bigger than the left here. The sulci are completely effaced in this patient, even at the vertex, and there is periventricular low density. Now, if you've got an old patient, they often have periventricular low density because of small vessel disease. Quite a useful place to distinguish between small vessel disease and transependymal CSF seepage is often the temporal horns and the atria. So small vessel disease is a little bit less prominent usually lower down at the lateral ventricles. It's very common at the level of the bodies of the lateral ventricles. This is a completely different pattern, as you can see. So we've got a colloid cyst, again, foramen of Monro, but in this patient, the third ventricle looks pretty proportionate to the lateral ventricles, and the sulci are quite dilated. So there's nothing really out of proportion about the lateral ventricles here. And there's no periventricular low density. So because of this sort of proportionate enlargement of the lateral ventricles, you would say this looks like a non-obstructive colloid cyst. And in a patient with involution. So involution the word means age-related volume loss. So you don't have to say age-related involution, but you can say age-related change or involution. So it's really a case of putting everything together. It's actually very challenging in some cases to decide if it's atrophy or if it's hydrocephalus or if it's acute or non-acute. So if you find it difficult at 3 o'clock in the morning looking at your patient, I think we all find it difficult at times to assess whether there's hydrocephalus. So let's move on to aqueduct stenosis as another cause of obstruction. So we've already talked about the pattern of this. So aqueduct stenosis is most often congenital, but it can also be acquired. And the third ventricle and the lateral ventricles are dilated. And the fourth ventricle is obviously normal. And the stenosis usually occurs in the proximal aqueduct. And it's described often as a web or a diaphragm, or can be due also to aqueduct gliosis. And so how do these present? Well, in kids, enlarging heads, bulging fontanelles, the sutures get widened and they can have the setting sun. If it's X-linked, so there's a syndrome called Vickers-Adams-Edwards syndrome, they will also have cognitive impairment and thumbs are adducted. And of course, clinically, they'll have symptoms and signs of raised ICP and chronic hydrocephalus. So up to 10% of adults with hydrocephalus will have aqueduct stenosis. So here we are, the best plane for looking at aqueduct stenosis is the sagittal plane. And you can see here this tiny little web at the superior aspect of the aqueduct here. You'll notice in this one that the proximal aqueduct is not enlarged because it's a proximal web. If you have a distal aqueduct stenosis, which is much less common, you'll see this funnel shape of the proximal aqueduct being enlarged. I thought I would show you the sagittal of the third ventricle. It's probably something that you as neurosurgeons, you're very familiar with. As radiologists, we don't look at the sagittal third ventricle in many cases, we obviously do in aqueduct stenosis, but I'm going to just go through the structures here. So this is a sagittal, so pituitary stalk. This is obviously the clivus, the sella, basilar artery, PCA, superior cerebellar. This is the pons and the midbrain. So if we go above here, we have the pineal gland. And there's a tiny little recess here called the pineal recess, this black arrow here. This little dot just anterior to the pineal gland is called the habenula. If we go to the X marks the spot, X is the posterior commissure on a sagittal, and this is the anterior commissure. Then you have vessels and choroid plexus, internal cerebral vein, and the cave envelopment interpositum sitting here is quite a large structure. The fornix sits here. This structure here, the anterior wall of the third ventricle, is called the lamina terminalis. Of course, this is the reason if you have an ACOM aneurysm, it can rupture through the lamina terminalis into the third ventricle. And then we have a little hashtag here on Twitter. So the hashtag itself is the infundibular recess here, and the little star is the optic recess. And then the curved black arrow, this is your tuberosinium. So if you're doing a third ventriculostomy, which we'll briefly mention later, you'll be coming sort of through here to do a third ventriculostomy. Now the reason I'm showing you that is just because, and again, this is exactly the same. This makes it look very clear. If you actually look at a patient, here's the anterior commissure, posterior commissure here, pineal gland just behind it. This is the pineal recess. Here we are with the fornix heading up along here, internal cerebral vein, cavum velum interpositum, and again your two recesses and your floor of the third ventricle with your basilar artery. So on T2 imaging, the arteries show up as black, or what we call in our reports flow voids, so normal major vascular flow voids. And of course this can be arterial or venous. So here's the further venous structures. So your key assessment, if you've got somebody with aqueduct stenosis, you want to do a heavily T2 weighted image. So depending on the MRI machine, it's called cyst or Fiesta. It's some machines it's called space, and you can do CSF flow studies. So let's moving on from, we've done that, so obstructive hydrocephalus, look at the pattern, think of what imaging you would like to do next for further assessment. So in communicating hydrocephalus, you have damage of the arachnoid granulations. So CSF, instead of being blocked, can't flow freely across the brain surface. And this is often due to subarach, meningitis of any type, can be viral as well, tumour infiltration, otherwise known as leptomeningeal carcinomatosis, or it can be post-operative. So you've got a bit of blood floating around after you've had surgery. So mainly post-hemorrhagic after surgery. So in communicating hydrocephalus, the ventricles will all be enlarged, and they will be enlarged out of proportion to the sulci. So massive enlargement of the third ventricle here. You can already see that the temporal horns are grossly dilated here. And as we go up, you see the lateral ventricles are really enlarged. What you'll notice then, with regards to the sulcal pattern, the sulci are relatively preserved. So again, this doesn't look like an acute hydrocephalus where you'd have sulcal effacement and periventricular. So low density on CT, or on MRI, we use the word intensity rather than density. So on MRI, you would have high T2 signal intensity or flare signal intensity. Now, we've already touched on the thing about, is it atrophy or is it actually communicating hydrocephalus? Well, I've already said it can be quite challenging. If you have somebody who's 80 who has got generalised involution, the key areas to look at are the third ventricle and the temporal horns. So even if you're 80, you have massive lateral ventricles, the temporal horns in the third ventricle may be normal. And of course, you'll look at the sulcal pattern. So if you've got atrophy, your sulci will generally be proportionately widened. And with communicating hydrocephalus, which wasn't the case in this case, they may also have crowding of the sulci. So more likely to have sulcal crowding if you have communicating hydrocephalus. And these are treated by shunting. So you normally VP shunt for these patients. So we move on to the special types. Now, I'm not going to talk about choroid plexus papilloma. I'm going to focus today on NPH. Choroid plexus papilloma is usually pretty obvious to see because you'll see a mass centred on choroid plexus, and it can be any of the ventricles. So NPH is pretty complex. I'm not sure anyone really fully understands it still. CSF dynamics are obviously involved in NPH. In choroid plexus papilloma, there are a few theories also. So again, maybe incompletely understood in some ways. So excess CSF production, tumour debris, which can also impair absorption of CSF, and this physical obstruction itself producing an obstructive hydrocephalus. So let's talk a bit about NPH. So controversial, the imaging findings are never quite definite. We often say in our reports, imaging is not a great way to assess hydrocephalus in some cases, or to assess intracranial pressure. And of course, some patients with NPH might not really have much visible on their imaging. But the triad is this awfully one, WWW, so wacky, wobbly, wet. So dementia, problems with gait, and urinary incontinence. But of course, not all patients will have these symptoms, and you're going to have a lot of patients who have just dementia who don't have NPH, but some patients with dementia who do. So there's always a combination of symptoms in older people. So the opening pressure in NPH is normal, and the classic neurological sign is a magnetic gait. So your feet are attached to the floor. So what do we see on imaging? So there are several features which we can assess. Temporal horns. Again, even for atrophy, these temporal horns look enlarged, and I think measurements can be a bit tricky. They say it's greater than 6 millimeters, but I personally don't tend to actually measure the temporal horns. All of the ventricles are enlarged in NPH, and the sylvian fissures are classically disproportionately widened. So more inferiorly, sylvian fissure, and more superiorly at the level of the bodies of the lateral ventricles, bilateral enlarged sylvian fissures. If we look at those on a coronal view, it can be actually much easier to see the widened sylvian fissures. And then on a sagittal view, if you have a sagittal, so our standard head protocol at Salford doesn't include a sagittal, but if you did have a sagittal, this is what you'd be seeing. Another feature very useful to look at, I find, is these what we call acute callosal angles. So you go to the level approximately of the posterior commissure and you measure this angle here. Now, this angle is acute. So in combination with the enlarged sylvian fissures, I would again here be saying this is probably going to be NPH. So you probably have heard about Evans index, and it's basically a ratio. So you take the widest part of the frontal horns and you divide it by the sort of maximum internal width. So it's a maximal internal diameter of the skull, and it's a marker of ventricular volume, and it's a very rough marker. And it can vary quite widely depending on which slice you're at. So again, it can be helpful, but it's not helpful in everybody. And it's not something I really use in my day-to-day reporting. I use it more of a history with the combination of imaging appearances. So in terms of treatment, just very briefly, it depends on the cause. If you have a temporary obstruction, so just say you're post-subarachnoid hemorrhage, you might stick in an EVD. If there's an obstructive mass, you might resect the mass. If there's no treatment, or if it's a permanent obstruction, so for example, if you have a tectal glioma, you may choose to put in a permanent CSF diversion. So most commonly would be a VP shunt. And as I mentioned to earlier, if you have obstruction at the aqueduct or below, you might choose to do a third ventriculostomy. And just to finish on hydrocephalus, so how do we distinguish between NPH and atrophy? Can be challenging, as I said. So this is a coronal CT, and this is a coronal T1. And you'll see the one on the right is atrophy, and the one on the left is NPH. So what you get, I didn't mention actually, are crowding of the interhemispheric sulci towards the vertex. This again is quite a really useful sign. So you'll see that there is no crowding of the interhemispheric sulci in this patient with atrophy. They've actually still got quite a large amount of CSF. The angle is acute in NPH, the angle is more obtuse. One of the sort of problems you might encounter, if you scrolled backwards on this patient with atrophy, you would find that this angle actually became more acute at the back. So try to not measure the angle too far back. The other thing here, if you have symmetric low density, you think, okay, is this small vessel disease or is it transependymal CSF spread? Well, really difficult to tell. Given the fact that you've got these findings, it's probably transependymal CSF spread here. In this case, where we think it's atrophy, this is asymmetric. So if it's asymmetric and you've got bits of small vessel disease, so white matter hyperintensities elsewhere, like these dots, so they're actually not periventricular, this looks like small vessel disease. And then we've got these special types. So I'm not going to speak about these special types today, but Hydrocephalus, ex vacuo, and Colpocephalus. So let's move on to intracranial calcification. If you've got any questions on hydrocephalus, maybe we can ask them just at the end. So we'll spend the next 15 minutes talking about calcifications. And we'll start by talking about normal calcification on CT. Those are quite a few things that can be calcified. So here's an axial non-contrast CT. So choroid plexus in the atria, the trigones of the lateral ventricles. The pineal gland at the back here, commonly calcified, and the habenula. So pineal calcification is actually extremely common, so 2/3 of adults, and it can be amorphous or ring-like, so it can be mixed, and it's usually under a centimetre. If you have more than 14 millimetres of calcification in the pineal, then you might start to think about a pineal neoplasm. So the habenula, which is what we also saw on the sagittal diagram, again, quite common. So 1/3 of the population will have calcified habenula, and it lies just anterior to the pineal gland. The choroid plexus is really common, as we know. One of the problems that we can encounter when there's calcification in the anterior third ventricle is mistaking it for a choroid plexus cyst. So if you start looking at the anterior third ventricle or foramen of Monro, you can get your eye in more for whether you think it's calcification or whether you think it's a colloid cyst. Basal ganglia calcification, really common, and in most patients it's incidental. If it's really prominent, I will probably mention it in my report. If it's an 80-year-old, I sometimes now, and it looks like this, I may not even mention it in my reports for a CT head. And it can be a little bit varied. So here it's actually quite well defined. It can be a little bit less prominent than this. It can be a little bit more faint than this and a little bit less symmetric. You would consider it pathological in young patients, and if it's a bit more extensive than this, and there are a whole number of endocrine and metabolic disorders that can cause it. So what else can calcify in normal patients? So the tentorium, phalanx, basically anything with dural reflection. So 10% of patients will have tentorial calcification. Now this isn't a consequence of previous subdural, but it can also occur as a result of various conditions. So basal cell nevus syndrome, pseudoxanthoma elasticum are two of them. And this can be a normal appearance in patients as well. It tends to be, it can often be anterior, but it can really be anywhere. So atherosclerosis is quite self-evident. So right vertebral artery here, bilateral cavernous ICAs in this patient. And to be honest, we see this in almost all of our patients in Salford who are over a certain age, not almost all, but a fair proportion have intracranial atherosclerosis. The petroclival ligaments, so as its name implies, so this is the petrous apex, this is the clivus, and of course the dural reflection, so petroclival ligament, very common. Let's move on to abnormal calcifications. So for abnormal calcification, there is a surgical sieve, and today I think we'll probably end up showing some vascular and neoplastic causes. We'll have a look at some of these other ones next week, and we'll talk about post-operative changes next week. I think as long as you know, if you've got a patient overnight or even during the day where you really don't know what's going on, use your surgical sieve. You can rule out a lot of these by the appearance. Again, in some cases, you're not going to know what the abnormal calcification is on CT just by CT, and you're often going to require another form of imaging, so CTA, CTV, even MRI, gradient echo. So let's go through a few. We'll start with the vascular lesions. So this is a patient who came in to A&E and trauma, and they had some bilateral swelling. Now this is too much for normal cavernous sinus, and there is probably some atherosclerosis. So I don't know how old the patient was. They don't look particularly young with this sulcal pattern, but they went on to have a CT angiogram. So that's the quickest and most effective way of assessing anything, like just say MCA bifurcation or ACOM or basilar tip. Quick way of assessing for aneurysms. And this patient actually did have bilateral cavernous ICA aneurysm, so larger on the right side. And this was an incidental finding. What about AVMs? Well, AVMs, they're not necessarily calcified, but a high proportion of them show this sort of dystrophic calcification, you would describe it as. An AVM, you have a nidus, which is basically the transition between the feeding artery. In this case, feeding artery is probably going to be distal MCA. They might have some abnormal posterior circulation feeders, but feeding arteries and draining veins. So draining veins can either be superficial or they can be deep draining veins. And there's no intervening capillary bed. And the nidus itself is often a little bit more hyperdense than here. So this nidus here isn't particularly hyperdense. But what you do see is a little bit of atrophy, and that can be due to what's called a Steele phenomenon, producing some ischemia. So if you have a combination of dystrophic calcification and what looks like volume loss, you think, okay, AVM. So what would your next test be? Well, again, you would do a CT angiogram. You could do an MRA, you could do an SWI, but the quick and most simple one to do is a CTA. Now, for aneurysms, we would tend to do circular Willis. So if this was for an aneurysm, the CTA would probably stop at this level. If you have an AVM, we would automatically extend this to the vertex, so we can actually see all of the draining veins. So you get a full picture of the vasculature rather than just the actual nidus itself. So skull base to vertex. Cavernomas can be quite tricky, especially in patients with trauma. You think, okay, is this a hemorrhage or is it a cavernoma? Well, and also people can also forget about cavernomas. So they tend to be relatively well defined. It's a cluster of capillaries with surrounding hemosiderin. They're usually supratentorial, but not always, and they're usually solitary, but not always. Like I say, sometimes it can be quite hard to see. The calcification in a cavernoma is usually described as popcorn calcification, and it can be familial. So you can have multiple cavernomas as well. So what test would you do if you think, okay, this person might have a cavernoma? Well, you'd move on to do an MRI in this case. And this is a flare, which we don't do in Salford. We do a coronal flare, actually not an axial flare. But the hypo-intense rim is hemosiderin, and you'd see this on T2 and flare. Now in this particular case, there is no perilesional edema. So if this was an acute hemorrhage, hemorrhages have perilesional edema, but early on it might be quite subtle. The fact they've got some CSF here would make you think, okay, there's no acute mass effect from this hemorrhage. So the calcification here would also be a little bit, would be very atypical for acute hemorrhage as well as this. So you'd be thinking, oh, this could be a cavernoma or even a tumour, to be honest. So on a T1, cavernoma can look a little bit more popcorn. So you get these foci of high T1 signal. And this is a post-contrast T1, where you see a sort of mild enhancement. Your key MRI sequence for somebody who you think has a cavernoma is to do either a gradient echo or susceptibility weighted imaging. So susceptibility weighted imaging is just a sort of like I don't know, Tesla compared to Skoda. Just shows you a lot more detail than a gradient echo. And we would use SWI in somebody, for example, where they were in ITU maybe and not waking up, and maybe if you thought they had DAI, you would use SWI wherever you could, because it's just a much more sensitive test. So for cavernomas, you've obviously already seen the lesion, index lesion. You're using these sequences to look for other lesions, which might influence future bleeding risk. Again, quite a tricky case here. This is pre and post-contrast CT. This turned out to be a cavernoma, but you'd wonder that this could be an intrinsic tumour with calcification and surrounding edema. They've clearly got mass effect on the fourth ventricle here, so it's displaced. Looks like there's sulcal effacement in the posterior fossa. There is, on post-contrast, perilesional edema, so you don't see that quite so clearly on the pre-contrast CT. And again, you would go on to do an MRI. So the reason for the edema in this case is because this looks like this patient has actually bled. So they've got high T1 intrinsic signal, but also this other signal. This is post-contrast. You can tell this is post-contrast primarily because of the nasal mucosa. So on a non-contrast T1, the nasal mucosa will be intermediate signal, and in a post-contrast, it'll be high signal. So yeah, the edema is quite obvious even on the gradient echo, and you can see the blood products in this. So this is a cavernoma which has bled, but again, quite tricky if you look at that initial CT. Just something to consider. And you answer the question by doing an MRI. This is, to go back to AVMs, this is a posterior fossa AVM. So this person comes into A&E with acute deterioration in conscious level. The fourth ventricle is expanded here and it's filled with hematoma. Now, the key finding on this is the dystrophic calcification. So this could be a posterior fossa aneurysm, which tends to give you more blood in the posterior fossa. But in the presence of this, and of course they've ruptured and they've got blood in the third ventricle and lateral ventricles, sulcal effacement, you've got to wonder about an AVM. So what do you do next? You go on to do a CTA. Now, very difficult to see the nidus of serpentine vessels on this CT. Very easy to see it on the CT angiogram. And you'll see the venous pouches. You might even see hypertrophy of the feeding vessel. So in this case, the feeding artery would be a posterior circulation branch. So it might be probably a pica feeder. They might have a feeder from superior cerebellar artery. They might have recruited from elsewhere, but posterior fossa feeding, and that's the nidus, so quite a large nidus. So last couple of minutes, let's shoot through another couple of vascular things. So this is, you would think this actually had been drawn on by someone, but this is a case of, so chronic repeated subdural hematoma. It's pretty obvious. Obviously some old blood in here, some old blood here, and bilateral calcification. What other calcifications might you see? Well, in the acute scenario with an appropriate history, this looks like a left MCA territory, and the fact that it's wedge-shaped rather than the sort of vasogenic edema that you would get from, for example, a metastasis or abscess. This is wedge-shaped and extends to the cortex as well as being white matter. And the key thing here is this little calcified embolus. So this is a distal left MCA branch infarct. Now, if this disappears and becomes atrophic, you will still see the embolus in future. And so the sources of these emboli, well, they can come from heart valves, they can come from plaques in the neck. And the density of these is much denser or higher Hounsfield units on CT than a thrombus. So a thrombus is much more intermediate density on CT, and it would be difficult probably to see a thrombus at this level because the branches are so tiny. As I say, it's most commonly MCA, and they do have a higher rate of recurrent stroke, and you would want to go on to investigate the possible proximal cardioembolic sources of these emboli. So before we, well, let's leave it there for today. We'll go through further causes of abnormal calcification, so neoplastic, metabolic, endocrine, next Thursday. We'll do again 3 till 3:40, and we will do the post-operative appearances next week as well. So for now, does anyone have any questions? I hope it was all fairly straightforward.
Can I ask a question?
Of course, Daniel.
Thank you very much. That was a really useful talk. You've seen some cases of IIH. You get a sort of empty cellar. Is that a sort of consistent feature across all patients who have sort of chronic hydrocephalus, or is it only specific to that disease?
So IIH would give, so intracranial hypertension gives you small volume ventricles normally. So they can be slit-like ventricles because you've got that raised pressure. Is that what you meant, Daniel?
Yeah, so I'm saying if in patients who have hydrocephalus for a period, do they also get that phenomenon where you can get a sort of empty cellar?
Yeah, not that commonly actually. No, I think probably maybe because the patient sort of compensates over time. So I don't know why, but no, we don't actually see an enlarged empty cellar in those cases with chronic hydrocephalus. It tends to be more supracellar rather than cellar, but I can't explain why.
Okay, thank you.
I see a question from Nafisa about Steele phenomenon. I may have to refer you to Google for that. That's not a very helpful answer. Sorry, Nafisa. Are there any other questions?
Well, thank you very much for your time.
Thank you very much. That was great, especially the bits, you know, those little tips and tricks on how to differentiate between NPH and atrophy, and also the transependymal CSF versus small vessel disease. Very helpful. Thank you.
You're welcome. So the Steele phenomenon, sorry, Nafisa, I feel bad for just saying. So the problem when you have a nidus is that there's so much blood going into the nidus itself that is being drawn away from, so you have a feeder and you have blood going to an abnormal area rather than to the normal parenchyma. So that normal parenchyma is actually being damaged because you've got an abnormality next to it. So it becomes ischemic and so it becomes atrophic. I don't think you see, well, I've never seen an acute ischemia because of course the nidus is something that's a chronic thing. So it's not an acute Steele. So you're not actually going to see acute ischemia of parenchyma next to the nidus. It's just a sort of, and not everyone actually has parenchymal atrophy next to a nidus either. So some will have this Steele and atrophy and some won't. I hope that answers it a bit better.
Thanks a lot.
Not at all. Okay, well, see you all next week at 3 o'clock. Bye for now.